The world's best physios don't just treat, they coach. Welcome to the Physio Coach Podcast. This episode is sponsored by Jane App. Jane is a practice management platform that helps clinicians like you and I spend less time on admin and more time caring for people. From online booking and scheduling to notes, reminders and billing, Jane is designed to reduce the day-to-day load on busy clinicians like us. After a few years of running Better Physio Group, we wanted to level up our practice management system. 10 minutes into the demo call and I was convinced. Use code Physio Coach 2MO, that's Physio Coach 2MO to get 2 months free. Sign up to the demo and see it for yourself. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio and then there's better physio. In the COVID lockdown, in 2020, I had this unique experience, as did many of us, where I was furloughed from work. My kids weren't yet, or my kid at the time was not at school. So I had a 3-month period where I was essentially the primary childcare for my son, and we went out and played loads and had loads of fun. His nursery then opened back up again about a month before I went back to work. So I had this even more unique experience where I essentially had a month off. Now, in that month, at least a week of it, I spent painting my house. And whilst I was repainting my entire house, firstly, I was incredibly bored because I don't enjoy that kind of work. Secondly, I then thought, well, how can I make it a bit more interesting? So I started listening to more podcasts than I've ever listened to before. And one of those podcasts was your podcast, Dr Oliver Thomson. And your podcast, the Words Matter podcast, was a really fascinating exploration of words and the words we use and not use and the meanings of those words in clinical practice. And I really enjoyed it. You've just told me today that it's around 80 episodes, and I have not listened to all 80 of those episodes, but there's a big chunk of them around 2020 that I did listen to in their entirety. So I've been following your Instagram page ever since and been intrigued and interested by your words in particular, but also some of the content that you put out. And lucky enough to have you in the episode today. And I've just realized that you have this unique situation in your working life where you are equal parts academic and equal parts clinician, and as we'll come to a bit later, also a business owner. But firstly, that the equal parts academic and clinician is particularly of interest to me at the moment, because I keep having these conversations with people about evidence-based practice and the challenges we have around interpreting that and using it as clinicians, and how complicated that can be when some people get wrapped up in it and are quite dogmatic about it, and other people are a bit more laissez-faire. Oh, well, my experience tells me this, the patient preferences are that. And what I wanted to ask you is, how do we make sense of it, and how do we use it best as clinicians, coming from an associate professor like yourself, someone who has a PhD, someone who really understands the academic world, but also as a passionate clinician?
Yeah.
How do we make sense of that?
Well, it's difficult, I think, first thing to say, despite, someone that's aware of the literature, and I'm very familiar with evidence-based practice models and the theory, and as a clinician as well, it still doesn't make it that much easier to apply. And I guess knowing lots about this area makes you realize actually how hard it really is to apply in a meaningful way with patients. So I haven't got a really kind of clever answer to say, well, this is how you take the kind of model of EBP or EBM and just kind of imprint it on your practice. I suppose what it's done for me, I think, is recognize the uncertainty and being comfortable with that uncertainty in practice. And for me, that means that evidence or research evidence doesn't map neatly onto people. It just doesn't. We've got we've got evidence which are derived from people in studies or trials, but yet the patients that we see in front of us weren't in those trials or studies. So there's a kind of gap there. We call it that gap of induction or inference. So I suppose succinctly, it makes me realise, but also comfortable, that actually this is all really quite difficult. And there are the pursuit to get the right answer, like clinical practice is a kind of maths calculation, and there's just 2 + 2 = 4. It's just not that way. There's a kind of multiplicity of kind of approaches, truths, and we'll probably maybe touch on what we have to have some sense of what's good or bad practice, or what's right or wrong practice, or ideal or not ideal. But by and large, it makes you recognize actually this is all really quite hard. And I think that the fallacy with EBM, and I guess the straw man, is that actually it simplifies practice and makes it much easier, and you just kind of pick the most recent RCT and just, oh, that's the RCT for exercise and shoulder pain. I've got a patient with shoulder pain. I just do what the trial says. It just isn't that easy. So I haven't got any clever ideas or any suggestions other than I think the value is with having evidence-based practice part of your clinical work is that it makes you recognize your own assumptions, your own values, and then you can be interested in the patient or the person's values and expectations. You've got this other type of knowledge which is derived from research. You've got this knowledge derived from your own experience. You've got all these bits of knowledge floating around. You've got the clinical knowledge derived from the examination, and you've got to somehow string this stuff together. And there'll be multiple ways of stringing it together, but nonetheless, evidence-based practice is your framework to give it your best shot, I think.
Is that not why, in the end, provided you are a reflective practitioner, you get better as you go? And in the end, those expert clinicians do tend to be older because they've had enough time to create enough connections in the mind between so many different touch points that it just takes time. And that classic concept of the 10,000 hour rule, which we know is not quite as accurate as we first thought it might be because it's a complex skill. So maybe it's more like 20,000 hours. But either way, it just shows you that you really need to be doing this thing lots and lots and lots, get lots of different data points in order to create a better map of the world that's out there, and why specialists perhaps get there a bit faster because they're seeing less variables because they're mainly focusing on a knee, let's say, and why a generalist, it just takes that a little bit longer to create all those variables for those different styles and types of condition that we see.
Yeah, I think I'm no philosopher, but I think a philosopher would say that experience, or kind of, there's an awful term for it, what is it called? Patient mileage, I think they use, right? Is necessary but not sufficient for expertise. So if we describe expertise as these kind of set of attributes around what it is to be a clinician, being reflective, clearly having knowledge, good communication skills, being able to kind of control that clinical environment, it's not just about hours. So it isn't just about time and just seeing lots of patients, because we probably all know really experienced clinicians who actually don't perhaps meet what we might consider or to have developed expertise. So it's got to be beyond just amount of time, but the kind of quality of that time and how reflexive you are within that time, and how in those moments in practice and then away from practice to really think about what went on and to question your assumptions, to really look back at that experience and learn from some of those experiences. So I think it doesn't happen automatically. I mean, I think it's fair to, it doesn't just play out through the function of time, that if we just live long enough, we'll be great clinicians. For some, maybe, but I think some of the other skills, and bring it back to kind of critical thinking, awareness of own assumptions, thinking about knowledge, what knowledge means, what is, when we talk about knowledge or evidence, what does that mean? What kind of meaning does that carry? And those sorts of questions and that kind of thinking, I think, facilitates that journey towards expertise. So, but yeah, clearly you need to see patients to have some clinical experiences to reflect on. Equally, you can just be seeing 20 patients a day and just going to run through them really quick. Everyone gets some bird dog and some manipulation and some whatever, without any real kind of reflexivity. 20 years down the line, and you're still doing the same thing. So I think it's both a combo of kind of time and clinical exposure, but also kind of meditating on some of those clinical experiences.
The original 10,000 hour study would have called that the deliberate practice part.
Yeah, I think it's not chess. Good enough. It came from chess, I think, wasn't it?
chess and musicians, I think, were originally studied, and the discreteness of the skill, the fact that it was they were quite refined skill sets, meant that you could be quite predictive on 10,000 hours. And then they realised that it didn't really map out to more complex skills like team sports and various other things that are a bit more varied, and there was a slightly different play out and things. But either way, I get your point here. Is that there's a bit more to it. You have to be deliberate with what you're doing, reflective and considered, and more cerebral about the whole process rather than just doing the thing. I want to come back to one of the things you mentioned around evidence-based practice here, and how the way we have to create evidence and the way we have to control so many variables doesn't map out to the real world. I was listening to a podcast this morning, the Sideways podcast by Matthew Syed. I really like that. It's the concept being that we look at it sideways and see it differently. It's a lovely exploration. The one I was listening to today is about the absurdity of the world at times, and they used an example which just made me think when you were talking about evidence. There was this public health study that was being done, I think it was in Denmark, and they were trying to use an overall exercise program to help people that were on sick from work. And they had this standard program that everyone did. It was part of the program. It was a giant study. And what they found was that it was becoming so demanding on people to do things the way that they were told to do it, that they then couldn't do their physio exercises, so they were stopping doing that. And that because they were just told to do it, they would just do it anyway. So they were doing this intervention, not doing their physiotherapy. There were some people that were way too fit for it, but they were just doing the thing anyway, so they didn't see any results. And what they then reflected back on was the absurdity of everyone just doing it because they were supposed to do it, rather than looking at what was really happening in the study and going, hang on a minute, this isn't working. So that word absurdity kind of rings out of, like, sometimes we have to think of that. Like, this is absurd, the way that people creating a study are intending one thing, a practitioner looks at it and says another thing, and that there's just this middle ground of like common sense that's needed a lot of the time, that we then just need to look at it and go, what are we actually trying to do here? How do we make that into a real world example? How have you managed to do that in your clinical practice, to take some of these potentially absurd studies and make sense of them?
But I mean, all these studies are absurd. If you go back to where EBM came from, and David Sackett was an epidemiologist largely, so he was really interested in large populations, a bit like the Danish group that you mentioned. How can we implement interventions to large numbers of people? And so this, I guess, that's just the definition of a kind of one size fits all, right? And then we get to the kind of work that we're in, where it really is like an N of one. It's a single individual with a particular set of values, a particular set of expectations, a particular set of kind of social and psychological circumstances. And yet we've got this kind of one size fits all broad trial, whatever it might be. And so, so I think that there are some challenges there. I think, again, how it works well for me is thinking that evidence-based practice is beyond the application of the trial, the Danish trial, but actually acknowledging that there's this evidence which is derived from a large population, but also there's equally important evidence in the way of your own clinical experience, your own expertise, your own judgment about what you think to be right or true, and then there's a patient's preferences and values. So I guess I come back. I don't go straight to the evidence. I suppose a mistake or a trap for junior clinicians is they write, oh, you've got knee pain, hang on, let me just do a quick PubMed search and see what I'm supposed to do. Okay, there's that Danish trial on knee pain, you're going to get that. But rather you start with the patient and you explore their experiences, their values. You think about, to what extent does this evidence, I'm going to use the Danish example now of the whole podcast, but this Danish kind of large population study relate to this individual with knee pain or whatever they've got and their circumstances. And if there isn't a relationship, if you can't see that patient in that trial, then it's potentially that trial's not relevant for them. So you still bring it back to the individual.
Yes.
And I think that's been either the misunderstanding, or perhaps when EBM or EPP came about, it really was general and population based. But actually, the kind of iterations of evidence-based practice with Tricia Greenhall and Roger Kerry and that whole crew is to recenter the patient in EBM. So you start with the patient and then go from there, and then bring the evidence in.
I think what it can do very well is create these guiding principles that you almost hold in the back of your mind as you're working through clinical reasoning. It's like as you're considering the person in front of you, you're thinking along the lines of, have they done enough of this so far? Have they got this for me to be concerned about? These kind of guiding principles that are locked into my mind, let's say around exercise. Are they sedentary or not? Do they tick that box? Let's say mechanical symptoms. Have they got this, this, and this? Have I tested for that based on those guiding principles, based on knee pain? Have they got inflammation? What do I understand from reading evidence about inflammation? So, and these days that happens very fast and without me having to think about that. But to begin with, there's a bit more of a checklist in my mind, certainly in the early years, of I've got to ask them this because of this, I've got to ask this because of this. And it's a checklist that I'm going through, literal checklists at times as well on my screen of that. Nowadays it isn't. It's a conversation that I could very quickly tick those things off and move on, or not, explore it in a bit more detail and then cover it. That's how I make sense of that as more of a clinician that understands the evidence side of things.
Yeah, no, I think that's, when you start out, everything's a checklist, right? From your case history, and you think, I could ask about cancer. I must ask about cancer. This poor person's coming with a sore big toe, right? And I've got to ask them. And it's very routinized, and it isn't necessarily tailored to the individual. You just got to do these things. And then as you just get, I guess, just better at it and smoother and better to think quickly and to think more clearly, and can thread some of these checklists into a conversation. So actually, even though on the outside, from the patient's point of view, it looks very much like a conversation, you're alive to some of these key things that you need to kind of find out. I think also the context within musculoskeletal care is that it's all the currency or the conditions that we see are all pretty swampy, right? They stuff seems to get better despite care, and we know that many of the interventions are really non-specific, and that just makes it a lot more difficult, doesn't it? There is some scope to get it wrong. So we know that there are people delivering poorly evident care for things like back pain, but yet the patients still get better. We can argue whether they're taking longer to get better, or perhaps things like self-efficacy or their own kind of perceptions around their problem aren't ideal, but nonetheless they still seem to get better. Like, it's, if we were going to take another disease, typically cancers tend not just to get better. In fact, almost certainly they don't just get better, or there does seem to be some specificity into the the formulations of chemotherapy. It would seem to matter what you take, whereas the kind of stuff that we deal with, which I guess is largely pain and perceived disability or dysfunction, like it just makes it also, it's great because you're liberating. Well, there are no right or wrong answers. I can do anything. The patient, you're given it a long enough time, that natural history, patients get better, or many do, but it makes it a lot more messy, doesn't it?
It also opens the door for pseudoscience, which I know is something that you have written a lot about, and it allows for that performative nature of care to come in. There's this lovely phrase that Rebecca Christensen, a guest on one of our previous podcasts, mentioned, and it's something I've heard before, that often we are merely entertaining someone whilst biology does its thing, and that is true, is what you just said. And sometimes the issue is around that entertainment. And how do you avoid for that, for one? But what do you sense? How do people become that? How do people become entertainers more than healthcare providers?
Yeah, it's a tricky one, because we know that things like having confidence in the clinician is an important kind of attribute of that therapeutic encounter. If the patient thinks this person is just useless, right? They're just not good. They're fumbling around. They haven't given me a proper examination. They don't seem to know what they're doing. That's, to some extent, going to predict some of that outcome, right? So we know we've got to appear competent. And so then you think, right. But then at the same time, a lot of the skills and methods that we use, the examination techniques, whether it's the kind of MSK stuff or the manual palpation, pretty ropey in terms of its specificity and its sensitivity and all that kind of stuff. But yet we still do it. Like, we know it's not very, not only is it not very specific or sensitive, actually, it probably doesn't, how you apply that intervention probably doesn't really matter anyway.
It's not valid either. But
we still do it. And so I do it a lot less, but I recognize that whilst there's some pretty sketchy evidence behind some of these performances, and whether it's being able to, hold someone's shoulder, or to kind of put your hands on someone's neck and have a bit of a kind of fondle around, to, you're saying you're feeling the muscles, but you kind of know that when these patients say to you, what are you feeling there? You're saying, I'm feeling the muscles. My evidence-based hat says you're probably not nowhere near the muscles, or you're on the wrong muscles, or so there's this real kind of contradiction in my own mind, but yet I still go through it. And I think the reason why I go through it is, as you said, is that there is some value in that clinical ritual. Is that I think there is value, despite some of these palpatory methods not having specificity. I think they do carry value to go through them. Partly as a performance to indicate to the individual that not only do you know what you're doing, but actually you care quite deeply about them. You're actually spending time trying to understand what's going on in and around their body. And I think there probably is some value, and there's that to kind of get a sense of how sensitive things are, how much things hurt, their own kind of sense of, when I put pressure here, what do you make of that? And what does that feel like to you? What are some of the cognitions and experiences that you're having when I do that? So it opens up some kind of topic of conversation. But at the base of it, from an evidence-based point of view, there's very kind of limited evidence support. It's not like these things are really essential components of practice. So I do it because I know, so at the same time, I should say that patients also come in as an osteopath, likewise with a kind of physio or a chiropractor. There's an expectation they're going to be touched,
which therefore makes it an essential part of practice.
Exactly, yeah. So they're now, we know expectations around outcome predict outcome to some extent, and also they're kind of paying punters, and so doesn't mean to say you give patients everything that they want, but it's just weighing up, isn't it? You're like, okay, well, it's pretty, there's sketchy evidence for this particular type of intervention, i.e. palpation and assessment with hands. But yet it seems to have some value to the individual. And if I don't do it, I think you've lost something, and you've lost them.
Well, and I think they might not come back.
Exactly.
And if I believe that I am the best person for their recovery journey, and that if they go somewhere else, they might not recover the way I believe that I can help them with, then I need to meet expectations so that they do come back and go through that recovery process and go through that journey. Yeah. So I fully agree with that. That I think that this, I guess we've kind of spun it on its head here, is that we are all performing, but the original question will come back is, at what point does that performative nature become a problem? Yeah, and I think probably it comes back to, I guess the bedrock is the kind of the ethics is this doing harm? And so if you and I did, let's say, identical performances, but you had a particular framing of that performance and particular words and language, and said, I'm palpating your sacral neck joint because it's really quite fragile, and I'm actually supporting it here. And if you created a kind of necebic environment and you removed some of that therapeutic, the therapeutic benefit, and you made it pretty scary, you started to engender beliefs or cognitions or a perception about their problem, which is problematic in terms of outcomes, then I think it's wrong. I think then it's not helpful. But I think if you can do the performance and either layer it with a positive narrative, a positive discussion about what you're doing, and actually this feels really strong, and I can see that's uncomfortable for you there, and can demonstrate some of that empathy, but kind of avoiding saying some of that mechanistic biomedical jargon which tends to freak people out. Well, it's both untrue and it freaks them out, and it changes how they're behaving, how they conceptualize their own problem. I think if you can do it without kind of saying any of that stuff, then it's all right. I think I'm at peace with it. Not loads of it, but I'm at peace with it. Me too. And we come back around here to the power of words and the importance of words. So clearly for you, words matter, and me too. I'm a big advocate of communication being an important skill in the development of an expert practitioner. The physio coach, I believe that coach element is hugely based on communication, is how well we speak to our clients, and how well we get those powerful, important, inspirational, reassuring messages across to people. Where did that come from you? So let's go back a little bit further and explore some of your history here. How did you firstly perhaps want to become an osteopath, and then at which point did you start to get really passionate about words and communication?
Goodness. And my journey into osteopathy was by accident. I mean, many of us accidentally find ourselves in these professions, but I think I was doing I know I was doing a sports science, sports healthcare degree, which didn't really lead to professional qualification. And one of my lecturers on the course, and so I was looking at doing physio or osteo or even medicine afterwards. Actually, I wasn't looking at osteo, physio, or medicine. And then one of the lecturers on the course said, "Oh, you should really try osteo. It's much more hands-on, and it's a lot more anatomy and whatever." And then I explored that, and I kind of read some of the prospecti from these institutions were also largely false and not evidence-based. That's another issue. Oh, that sounds fantastic. I can do these amazing things. I can kind of reach into the soul of my patients and get them better. I'll do that. That sounds much better than physios who are just giving knee extension exercises. That was the kind of the myth. So that was my route into osteo. But my route into kind of language and communication, I suppose, probably came about when during my PhD was predominantly interested in how osteopaths approach practice and how they see patients, the variants that osteopaths take. So there's that old, I don't know what the expression is, but you see 5 osteopaths, you get 10 different answers or diagnoses. And so the way in which I tried to understand that problem with my PhD was qualitative research. So I did interviews with osteopaths, and I did some observations and some video recording. But with qualitative research, you're particularly interested in language and the way that you ask a question, and also what comes back. And I think that was probably that started my interest in, God, if I there are certain words that we're all using, but we kind of assume meaning to these terms, and actually there's lots of meaning subjective. So that got me interested in thinking, wow, what are we saying to patients? So I took that kind of interest in language and conversation and understanding how people express themselves and the kind of social aspect of research. And then as a clinician, I thought, goodness, there's some relevance there to my patients. And I guess concurrent with that, there was being put off by some of the kind of manual therapy side of care. So there's an automatic kind of drift towards more conversation-based care, or at least still doing the kind of manual stuff. But that would just happen because I thought that's not very important. I mean, how I do that, beyond notwithstanding what we said about the performance, the performative aspect of it is probably more important than I connect with this individual through conversation, and then in the background the kind of manual stuff happens, rather than typically it's the manual stuff at the foreground, right? It's all about, you've got to get that right, you've got to push in the right spot, rotate the right bone, all that kind of stuff. And the conversation is either discouraged because you're working and you've got to really focus and the patient shouldn't speak, or it happens at sporadic points.
There'll be a lot of people out there that will disagree on the manual therapy side, right? There'll be some very passionate manual therapists that'll really sense they are better at it than average, and they get outcomes when others don't. And there's a part of me that does believe there is a truth to that. When I read the research, it then challenges that belief as well, that the research says that doesn't happen. The individual experience says that it does happen. My individual experience is that occasionally it does happen. Sometimes my manual therapy does nothing. Sometimes it works wonders. And I don't think I'm necessarily expert, by the way. I think I find this spot that hurts and I push it. And I'm sensitive enough to work with the person in front of me, and I go with them. And as a result, I modulate pain occasionally very effectively, and then I move on with the rest of my treatment techniques. And it's always wrapped up in language and words and discussion and exploration. how do we try and make sense of this difference in opinion here when I have some very trusted colleagues who I know use manual therapy in a very detailed way and specific way, and I have some others that are like, no, I don't use manual therapy, it doesn't work.
Yeah, so I'm not like that. So I'm not of the view that it doesn't work, or I don't, it's no good and we should drop it. But I think when we say, I used to teach manual therapy to osteopaths, and there's always an expression we used to use with students, well, they've got very good hands. That was the word that the phrase that people would use to describe students that were just really competent at manual therapy. And I suppose if we go back to us as students, when you'd practice on each other, and the first time you held a neck, or let's say we say you were a body, so someone was practicing on you, and how uncomfortable it felt. You're a bit shaky, and you've got heavy, 5 kilo head in your hands, and you're a bit cack-handed. It's all over the place. Compared to someone that's been doing it for a long time, and you develop those kind of psychomotor skills, and you're far more confident, far more relaxed. You can engage with the person whilst doing this kind of psychomotor skill. I think, so as an example of kind of the experience on the patient, like there is a difference there. There's a difference in how you perform that skill. If it's confident, if it's engaged, if it's attentive, if it's bespoke to the individual, and you're kind of changing pressure and tension based on what you're perceiving, that all seems to be like, we do that in conversation. We kind of do that to tailor our behavior to different social situations. So it seemed to me that there is value in doing manual therapy. You can definitely do manual therapy well, and you can do it badly. And we were all bad as students, right? We were useless. I remember the first time I couldn't do anything. So I think that it's that which derives maybe a better outcome. What I'm pretty confident isn't. So your colleagues that say that, maybe they're not saying this, but individuals that say I'm brilliant at manual therapy, I'll say that's possible. You can be excellent at manual therapy. But the reason why they're excellent isn't because they're specifically moving L3 to the left and L4. We know that's not to be true, but actually there's some other quality or qualities about their, that tactile engagement, whatever that might be, reassurance, confidence, all the things that I said. And that's really important. That's not necessarily easy to develop. It's a really valuable skill, but I think it's, but the interesting thing is that it's often not sufficient. If you say, no, but you are good at manual therapy, but you're good in this way. For many people, no, I know I'm good, but I'm good in this way. It's not enough. And I think, I think partly because it's just much cooler to say that you can, be very specific in your intervention. It shows that you know more and you can do more than patients or others, and there's a value that's derived from there. But it doesn't seem to be the case.
How important is it to find someone's pain?
I think it's important to explore someone's pain. I mean, we all do, don't we? And finding pain or looking at kind of someone's sensations and getting a sense of how it feels for them. But you're right, you can't deny that moment when patients say that relief when they say, "Oh yeah, that's it, you've got it. That's it. That's the pain that I've got," and it probably, it may be the pain, or maybe it's done. Whatever. It's something which is relevant for them.
Yeah.
So I think if it's relevant for them, it should be relevant for us. Yeah. And I think that the worst thing that we could say is that you can imagine that patient that's had this pain for many, many weeks, months, years, and we just don't really care about like exploring that sensation with them, and how disappointed they'd be in that clinical interaction. But I think it's a valuable goal to explore that, find that pain, and then you can have a discussion around that. What does that mean for you? These are my thoughts about this, and you can go from there.
Because I've heard that from patients before. They will come in and say, "I saw this physio. They couldn't even find my pain." Yeah. That's physio. And it's almost the first thing that they say. So clearly, it's a very important part of that therapeutic alliance is that you can find their pain one way or another.
Yeah, or to look at. I mean, I saw my GP. They didn't even examine me, right? And poor GPs when they got the time to do this. But then you think, crikey, right? And then they're partly undressed or not in your clinic room, and you're looking at them from the back. What am I looking at here? Like, we kind of know that shapes of spines are all varied and there's all this kind of variance around structure. But nonetheless, I find myself observing how someone moves. But I think with people like Peter O'Sullivan, they kind of layer on a new framework to understand how people move. Actually, I'm not so interested in how the segmental motion when you bend forward, but I've got cues around confidence or fear or safety or some of those cognitions. So it's funny, I find myself doing the same kind of stuff I was doing 20 years ago, but there's a different theory that underpins it. There's a different framing of it. And so practice, and maybe in fairness, well, definitely the bias has changed. I do less manual therapy, but when I do it, it's got a different kind of tone to it.
Yeah, I agree with that. I agree. Something we really love about Jane app is the way things look online. So when you click book an appointment on our website, it directs you through to Jane app's booking system. And the colours are nice, the design is good, we're able to make it bespoke with our logo, with our colours. You can see the faces of all our providers straight away, so people can click in with who they want to book with. If you've got different locations, you can click in which location you want to book. It just makes things look really professional, really slick, easy on the eye, and really, really in line with our branding. Another nice thing about the online booking, you're able to put a little note on the top, so you can put messages there about different things that are important. But what we've used it for is it shows the insurance providers that we work with, and it shows the insurance providers that we don't work with. So there's no complications, no friction when someone books in by mistake and then they get to the point of the session and then we have to tell them that we actually don't work with the insurance provider that they're with. So it's actually taken away quite a few complications that we used to have with previous systems. And now back to the episode. And some of what we're doing here is also is slightly tied to the identity of the therapist, and we could talk about firstly the umbrella nature of a therapist, an allied health professional, and then there's the more specific titles of osteopath, chiropractor, physio, and I strongly believe these days we're a lot more similar than we are different, and I understand you share that belief, and yet one of your papers quite interestingly is titled "What's Wrong with Osteopathy?" And I know that you then had another paper that was also "What's Right with Osteopathy," which
no one's
I
read
think
that.
they got a bit less attention, didn't it? But what were you trying to highlight there with that provocative title of "What's Wrong with Osteopathy"?
Yeah, and with "What's Wrong with Physio," there are. Firstly, the title of the paper, "What's Wrong with Osteopathy," came about. Again, when I was a PhD student, there was a paper or a book called "What's Wrong with Ethnography," and ethnography is a form of qualitative work where you are really interested in the observation of kind of cultures and how they behave and how they interact. And there was a book called "What's Wrong with Ethnography," and subsequently that really struck me as a cool title for a book. And then moved forward. I know that was probably in the 80s, that book, but when I read it in 2012, 2013, moved forward. I think when I wrote that paper, "What's Wrong with Osteopathy," in do you know when it was? 2021, 2022? Around COVID time, I think. Just after. I think I was just going through I woke up in a bit of a grumpy mood one day and had a lot of these thoughts. And then I started to write. I started to lay out issues that I saw with the discipline of osteopathy. And not necessarily with osteopaths, not with individuals, but with the practice of osteopathy and the theory of osteopathy. And it was titled "What's Wrong with Osteopathy?" Because I remember that book that I saw as a PhD student. Subsequently, there are papers titled "What's Wrong with Radiology?" "What's Wrong with all sorts of things?" So it's within academia, it's quite common to take this really critical stance towards an idea or a concept. So within academic circles, it was welcomed and it was a brilliant paper, well done, really scholarly work. But some clinicians understandably just thought, what is this guy doing? He's just completely slagging off. He's an osteopath for a start, and he's kind of slagging off osteopathy. But I still think I think it was an important paper for me to write. And I don't know. I mean, it's hard to say whether it probably didn't shift anything, but it certainly got people to reflect, or some people to reflect a bit more on the profession and what they're doing. Obviously not everyone, but no, it really laid out, I think, 5 areas where I thought osteopathy was deficient.
What are those 5 areas?
I've got to remember now. One, so there won't be an order, but one was osteopathy is inherently biomedical. So it really, Osteopathy put its eggs in a kind of anatomical basket, in so much as it came about at a time where the chap that developed it, Andrew Taylor Still, was observing anatomy and physiology in wildlife, in animals, and so it trickled down that anatomy and structure and physiology and all that was really important to health and disease. It turns out that actually, at least for things like back pain and neck pain, anatomy is less important. So it was very biomedical. It had these kind of implausible, has a tendency towards these implausible mechanisms. So trying to connect all bodily systems to the spine, for example, or you could, and as I say these, there'll be someone saying, well, that's not a theory in osteopathy. These are examples. But, thinking that you can release fascia to help the function of the kidneys, so you could help kidney pathology. So I have these implausible mechanisms, these biomedical beliefs. There's a tendency for osteopathy to be practitioner-centered, to be really focused on the individual. And a good osteopath is measured by how good their techniques are, how good their manual therapy techniques are, how much anatomy they know, and less talk around the patient, the person. Goodness.
But as you say that, I think, well, equal criticism could be pointed at
100%,
physios, and chiropractors, right? That stuff is relatively universal here in its critique, critique accuracy. I would say is that the opposite of those things. I'm sure that covers what's right with. Like the opposite of those things, it tends to make good practice and good practitioners as well. So,
we said that. I'm sure we said that in the paper, that this argument could be put to any healthcare professional. However, we're osteopaths and we're talking about this is our perspective. And I suppose the caveat I need to make clear is that, and I guess this was the challenge of the paper, and I think if I was going to write it now, it would be different, that I was generalising that all of osteopathy is like this. And I don't think it's true. I know many fantastic osteopaths that don't subscribe to some of these things, but nonetheless, it was a way of kind of understanding there are these thoughts that float around the profession. It's not the case that they're dominant or universal in the profession, but they are there. And so, but it was a tricky paper to write. And like I said, if I'm going to write it again now, probably mellowed out a bit at my older age, I wouldn't write the same paper. I still think some of the arguments hold though.
And I know that to be true because some of your other writings have been about the variations in osteopathy and how different people clinically reason. So what does that look like when you really look at clinical reasoning across a profession? What are some of the variances, but also perhaps the good similarities that make up osteopathy? Yeah, no, good one. So my PhD looked at just that. I was muddled as a student, where you'd have a clinical tutor. So with osteo training, we didn't have kind of NHS placement, and like you have in physio, but you'd have these clinics which were attached onto the educational institutions, and you in your third and fourth year you'd see patients and you'd be supervised by a practicing osteopath, a kind of clinical tutor. And as a student, I was amazed by you have the same patient, Mary, for example. Over the course of her 10 weeks of treatment, you have 5 clinical tutors that would dip into your room and have a look, and then you'd be 5 different opinions. So, God, they're all completely different. How does that work? This is just madness. So as a student, I was puzzled by the fact that there seems to be this variance in practice, not just what people do, but also how they're thinking about their patients. And that then kind of drove me to try and understand the kind of the UK osteopathic scene. Back to your question, in terms of what we can say about clinical reasoning across the professions, there seems to be a kind of pretty standard way of formulating diagnoses between doctors, physios, osteos. I'm not sure about the evidence in chiro, but I'm going to presume it's going to be the same, where we've got 2 broad cognitive processes of generating a diagnosis. We've got one of hypothetical deductive reasoning, where you're generating a hypothesis, testing that hypothesis through collecting more data through examination, modifying that hypothesis, and then kind of formulating a diagnosis. So that kind of stepwise approach. It's patient comes with knee pain, and I believe it to be,
or I hypothesize it's some plica issue. I'll do some clinical tests to confirm that it's correct. Then I've deduced that it's whatever the thing is. And we see that more in kind of less experienced clinicians, because it takes quite a bit of time. You're collecting data, modifying it, collecting data. The other type of clinical reasoning, which again occurs across healthcare, is this pattern recognition which is based on experience, and you can forwardly reason or inductively reason to the answer. Because a patient comes in, they've got this collection of signs and symptoms. It kind of mirrors something that you've seen in the past. You can quite quickly string this together, and you can leap to that diagnosis. So that seems to be the case. At least in my research, osteos developed that or exhibited that kind of clinical reasoning or diagnostic reasoning. But so do physios, so do doctors, so does everyone else. That wasn't very special. Everyone does that. But I guess what was interesting with the other bit of my PhD was looking at how osteopaths conceptualize practice, and that's a tricky one. But that really says, how do you view the nature of your skills, your knowledge, your professional identity? Because how you conceptualize and view those will inform how you interact with patients. And there does seem to be a bit of some variance within the profession, at least in the UK and France.
So less variation in the way that we clinically reason, but more variation in the way that we share that reasoning and share our understanding of what that really means for the person.
Yeah, and also our clinical gaze. So what comes with conception of practice? If your view about what clinical practice is speaks to the kind of physical structure of someone, or the kind of cues you can derive from palpation or looking at someone's movement, then there'll be a kind of a clinical behaviour which will be in accordance with that. If your view of clinical practice and actually it's really focused on the person's kind of lived world, and it's a much more social kind of enterprise, then your kind of clinical behaviour will be different and in line with that. So kind of how you view practice to be will inform how you interact with patients. So, but the cognitive process, the kind of machinery in the brain that takes place, osteopaths aren't some weird species. They've got different cognition. That's pretty standard.
How do people come about that clinical gaze then? Have you looked into that question?
Yeah.
Because
I've actually got a PhD student now, Chris Wilkes, we're asking that very question. So we're saying, okay, the work that we've done through from my PhD but to now, we've kind of described this variation in how osteopaths conceptualize practice, done in the UK, Australia, France. We're doing it in Scandinavia and a few other places. But how do people get there? Like, how you're not just born with this kind of way of thinking about practice. So his PhD is going to track kind of longitudinally, so follow a cohort of final year students in their third year, and then follow them over a period of time to see how they evolve. What are you like in year 3? What are you like in year 4, your final year? And what are you like in that first year of practice? And we might get a sense of how these conceptions change, how they evolve, and where they come from.
So to me, that suddenly sounds like a fascinating way of looking at things in that, because I've got a pretty strong sense that the fact I did sports science strongly shaped the type of practitioner I became. And the fact that I worked in sport strongly shaped the practitioner I became. The fact that my first job was in a factory with a load of people with socioeconomic problems strongly influenced the type of practitioner I became. I really feel that to be true. And the fact that I was in a leadership position very early on strongly shaped my ability to then do that further down the line. So I think that's going to be a really great thing to look back on. And I mean, hopefully that you could then take that even further, because how interesting would that be to then look at that? A bit like some of those big, long lifetime studies, right? To keep looking at those same cohort.
Yeah, and that's the challenge. The design is hard, that longitudinal design, it's good. I don't know how we're going to do it. It's part of the PhD, but that's the funding. Yeah. And it will never be as big and as fancy as you think it will be. But just to track or to follow a cohort through, I don't think it's been done yet. Certainly not in osteo. I'm not sure where it's been done. Often you just take a snapshot of a year 3 survey, then a different year 4, but they're just snapshots in time, right? Rather than following them through. It just takes so long.
Because if you then understand what it is that does shape those people, you can then start to think, well, how do we, if we find really good practice and define really good practice, how do we then shape that from the beginning?
Yeah, exactly. And our intuition is that the clinical tutors I mentioned when I was a student, so these practising osteopaths who have a dual role, they're in clinic for their own practice during the week, and they come and do some work in the teaching clinic. They're quite powerful in terms of modelling. That if they come in and espouse a certain view or method or technique or have a certain way, at that stage they're really quite transformative or informative for those graduates, those students. So we reckon, part of Chris's PhD will be to observe, actually, to go into these clinics and also see some of those interactions and generate some data that way.
This again sort of starts to confirm this theory that we're more similar than we are different, and that I love that reality. I think social media has had a big role to play in helping people to learn from similar good quality information and people. And yet there is still an element of professional identity that exists, and I don't necessarily have a problem one way or another with that personally, but I know it exists. I know some people are very strongly identifying with being physiotherapists and also osteopaths.
Yeah.
Where does that come from, and at what point do you think that can become problematic?
I think where it comes from, I'm speaking from osteopathy. Osteopathy's got this interesting journey where it's it was developed in the US in the late 1800s by a physician who was dissatisfied with the kind of medicine that was taking place in Missouri in the 1800s, as anyone would be, right? Medical care was miserable. They were using arsenic and mercury. It was rubbish. So he thought, actually, I could probably, if we just don't give people arsenic,
do no harm,
and we kind of fondle around in terms of manual therapy, and like some rudimentary manual therapy, it turns out they don't die, right? And based on some actually blood supply matters and all that kind of stuff. So Andrew Taylor still kind of pieced together osteopathy as a kind of idea, and so it kind of sat out. At least in Europe, it kind of sat outside medicine and physio. So it was his own thing, had his own set of ideas and premises. Whereas, you correct me if I'm wrong, physio has a slightly different relationship with medicine. It's kind of not come from medicine, but it's in the same kind of paradigm as medicine, right?
It runs parallel to it, I would say.
Same with nursing. Yeah. It's not. Whereas osteo was kind of created. It's this. I want to say this kind of crazy idea. It wasn't a crazy idea, but this idea that an individual had, and this was quite interesting. We can trace osteopathy to a founder. Can't do the same with physiotherapy. There isn't a founder of osteopathy. There's a founder of physiotherapy. There is of osteopathy. So what comes with that is a very strong set of connections to this one person, and what this individual said, and what they wrote about, and what they thought osteopathy to be in the 1800s. And for some people, some osteopaths, that their preference is to carry that idea of osteopathy through to 2026. And I think there's issues around credibility, and wanting to perceive to be different from physiotherapy, which was the established, I guess, kind of allied or kind of analogous profession. So for some osteopaths, a kind of preserving that identity to be different. I know it's important that we're different. We're not like physios, we're not like chiropractors, we're not like massage therapists. We're different, and it's important that we're different and have a point of difference. In countries where osteopathy is yet to be regulated as a profession, that's really important, because if you say, for me, from the luxury from northwest London, where we're regulated, and there's very little kind of difference legally, ethically, medically, professionally, it's easy for me to say we're all the same. But if you're trying to professionalise a group of osteopaths and you're trying to get trying to lobby government to regulate, you've got to say we're different. If you're the same, they'll say, why are we going to regulate you? So I get that there's political reasons why and social reasons why osteopaths want to remain different and unique in that respect. But if you look at the evidence, it doesn't seem to be much difference, really. We're all using the same interventions, same sort of care. We see the same sort of patients. But I guess there are incentives for some people to preserve that difference, whilst there are incentives for others to kind of blur that difference.
What about through the lens of the patient?
Yeah, I think patients care too, don't they?
Yeah.
Well, I never see a physio; they're rubbish. They just give me exercise.
Physio doesn't work for me.
Yeah. Chiropractic, he just cracks me with the osteopath. No, I mean, and we've all heard it. Everyone's heard the same stories from patients. People always ponder what would it be just to get rid of the professions. You had a kind of musculoskeletal profession. Does it makes it simpler for the patients? Some would say, well, at the moment these names, osteo, physio, chiro, give some sense of the landscape of like MSK. You kind of know what you're going to get, recognizing there's lots of overlap. Whereas if you have MSK, it kind of removes that possibility for patients to choose. But it is kind of bonkers. It's like having 3 types of dentists. Imagine that. What do you do?
I mean, I'm a bit of an idealist, and I often think, why don't we just do that? Call everyone musculoskeletal practitioners. Like, that sounds great. Like, that sounds like it simplifies so much of what we do, certainly from a teaching perspective. But then I think on the other side of it, people go, but that takes away our identity. And I think that's why this was quite an important thing to discuss here as a physio and an osteo, that have a lot of shared beliefs and a lot of shared values about how we see the practice in a good way. And that, it clearly is me sitting in my, idealistic chair on a high horse and going, let's just flatten the whole thing and just call it musculoskeletal care. And surely that's easy. Obviously it's not. I have no idea on the practicalities of that whatsoever, but certainly from a philosophical perspective, it seems to make more sense than not to me.
I think so. I think that's you and I saying that, who are kind of middle ground centre clinicians. They'll be the kind of fringes, that's the right term, fringes of our professions, who are like, no. Like these theories are unique to physio. These theories are unique to osteo. They're different. We've got to preserve them. And they would kind of lobby there'd be good reasons in their mind not to, or to remain distinct. But, it's such a bizarre, like I said, I come back to like dentists. It's just if you had 3 professions that were all dental professions, I mean, how do you... It'd be confusing, and what's the point? Government have got to deal with 3 professional bodies, 3 associations. But it won't happen in my lifetime, or probably yours. I think there's too much resistance, unless it's forced on government. I mean, within our institution, HSU, I think we're the first one in the UK to offer degrees in osteo, physio and chiro, which are quite interesting. I know there's an institution opening up in Sweden which are going to be doing the same, and I think Australia, Vic Uni are now offering the 3 professions.
So that's the first phase of it then, isn't it? At least bringing these people together in the same institution to train them differently, but to train them, at least there'll be overlap, more overlap than there usually would be. So
and I'm not speaking about HSE, my views differ from those, but you can imagine if you were running a university which had the 3 professions and you had an anatomy class, would you put 3 separate anatomy lectures on?
That's sort of what... You put them together,
right? You couldn't have necessarily.
Well, I'm thinking of my sports science degree, and in the first year especially, there was a lot of classes where there was a whole range of people. There was biomedical sciences in there. There was the I think there's some like master's stuff that was in, like some of the master students are coming along to those lectures because it was different to their usual stuff. And that no one blinks an eye, right? It's like, whatever, it's fine. So it makes sense that you start to connect more people, and then you get even more shared ideas and even more of a, we're more similar than we are different. And maybe this is the start of it after all. Who knows? But my sense is that it would have to be politically driven from the top, from government to say, hang on a minute, we're restructuring the entirety of healthcare, and maybe they might have to because of the way things are at the moment. So it'll be that shapes it.
And I think with that said, there are more and more osteopaths within NHS type roles which they're not osteopath roles, but they're pain clinician or MSK clinician roles. And so I think that's great for the profession. It's great for new grads coming out that now have, rather than just the binary choice of private practice or going to academia or something, they've now got NHS type roles, whether it's through not Connect Health, whatever they're called now. But so I think that's encouraging for the profession that you've got osteopaths within working alongside other AHPs, which wasn't, again, 10 years ago, that was hardly the case.
Words matter for you, very clearly, and you seem to be quite careful with the choice of your words when it comes to the titles of certain papers and the theories you put out there. A couple of these papers and a couple of these theories really stood out to me, and I just like the sound of the words without necessarily knowing entirely what they mean. But the first one of these is Anatomical Possibilism. So when we put those two things together, it sounds poetic. But what do you mean by that?
It's not mine. It's not my term. It's a paper that I co-wrote with a Spanish physiotherapist, Diego, who's also known as the Skeptical Physio
I know
Instagram.
it.
Yeah. And I think he put out a post a few years ago now, just named Anatomical Possibilism. I'm sure he did. And I thought that was bloody great. Let's develop it into a paper. And so, with another colleague of mine who wrote the What's Wrong paper, Andrew McMillan, we kind of put together this Anatomical Possibilism paper, which really speaks to this fallacy, which is in osteopathy but is everywhere, right, within MSK, where you just because everything's so. I think the subtag or the next part of the title was it's all connected, so all matters, something like that. So because you've got this view that, well, everything's connected, the earlobe's connected to the big toe through some fascial chain, then you can construct some explanatory theory as to why you should be mobilizing the ear for bunions, right? It's not, but then it just becomes so ludicrous because everything's connected. You just say what you want. There's this kind of nihilism. You just say whatever you want, and that's a problem because it's not helpful for the patient. It's not supported by evidence. So that's what Anatomical Possibilism spoke to, was this clinicians seeing that because by using anatomy and the interconnectedness of anatomy is to explain away every therapeutic behavior or encounter or intervention.
Which comes across very biomedical again, doesn't it? It skips
exactly.
out the psychosocial. And as we would both agree, biopsychosocial model is as close as we've got to something that connects everything in a meaningful and evidence-based way. The next couplet of words is therapeutic pluralism.
Yeah.
Another very poetic choice of words there. And therapeutic pluralism, what does that mean in both good and bad terms?
Yeah. And I guess it speaks to this variance in care, that we should be open to and not dogmatic and not dictating care. And probably, earlier on in my career, I was like, no, there's a right way of doing it, and you should be doing this, and you shouldn't do that. But I think we should, I think we should be open to allowing people to express the kind of care that they want to deliver. But with all these things, what are the edges, right? When is it dive into? If we accept that actually there's room, it's a broad church, and there's many ways to do the kind of MSK care, osteopathy, but taking that kind of completely relativistic view where everything's allowed, it starts then. When is it? When are we into bad practice or poor practice? And so I guess pluralism might be that. I don't know. I think we still got to have some sense of what is optimal care, what's ideal care, what's and a very good sense of what's ethical care. I think I think there will be some kind of ethical bedrocks. Like, it's probably fine to let patients choose what colour acupuncture needles they want, right? That's fine. But it's probably not okay to needle directly over the lungs or something. Okay, we can have a so I think we need to have some good boundaries, and obviously that's what kind of codes of practice are about, and kind of regulatory standards is to make quite clear what some of those boundaries are.
And then we've got a big chunk of grey area that's complicated. Yeah. A manipulation is something that we both know is not going to lead to any measurable permanent change over the long term, but in the short term, a lot of people will leave feeling fantastic, and they will then gladly pay for that over the long term. So where does that murkiness become problematic? It's sometimes you almost, is that in the eye of the payer? Or is that not quite as simple as that, because it depends on how that has been explained to them by the practitioner, and the benefit versus cost has been explained.
I think that problem motivated a fantastic episode on the podcast with a medical ethicist called Claire Delaney. And I can't remember what number the episode was, but it was just that. It was saying, should we always give patients the type of treatments that they want? Exactly that problem. Like, particularly when you're in private practice, is this kind of commoditizing of care. Well, I want a manipulation. Here's some money. You do the manipulation. Like, when is that not okay? I think I can't recall exactly what you said. It was some really wise words, but I forgot them. It's about the stakes, but how high the stakes are. So coming back to the acupuncture, letting patients, and that might have been her example, letting patients choose what kind of acupuncture needles. The stakes are very low, whether you have the red ones or the blue ones, makes no difference. Patient that's got clear cardiovascular risk factors and yet blood pressure through the roof asking for a manipulation, and you say, okay, then you do a manipulation, that the stakes are quite different, aren't they? So I think when it's low stakes and kind of low kind of existential risk to them, there is room for, like, there is room to kind of to accommodate, maybe, is that the right phrase? But there is this kind of do no harm, this kind of bedrock of ethics. If doing something which you know to be harmful to the patient, despite them requesting it and still going through with it, that seems to be outside of what you'd expect from a professional, I think.
As a practitioner, referencing my background in sports science, my lifelong commitment to exercise personally, my work in sports, working alongside strength and conditioning coaches, both in the sports world but also the clinical world, has led me to develop a genuine skill in personal training, and that has been a real benefit to my rehabilitation skill. I know that I can rehabilitate really well, really accurately for a lot of different conditions, because I understand those guiding principles of strength and conditioning. What that has also done is that a subset of my caseload is personal training. And there'll be some physios that would think, hang on a minute, isn't that outside of your scope of practice? But it actually isn't for me. It's well within my scope of practice, and I'm very comfortable delivering an early stage, foundational level, sometimes kind of blending into intermediate level personal training for someone. At some point in that journey from physio to personal training, there is a blurred line of at which point has it shifted. And I'm normally quite overt about that with the client. I'll tell them, haven't you noticed that recently this has become a lot more about personal training than physiotherapy? Would you prefer to see a personal trainer rather than me? I have a team that helps, right? I've got a team where there's PTs in the team. They'll deliver this. In my opinion, they'll probably be better than me, you know, and I'll be quite explicit about that. And most people will either drift away, or they will go to one of my PTs, or they will carry on with the learnings I've provided, doing their own sessions autonomously. All of those outcomes I am very happy with. But there are a small subset of people that say, well, why would I do that? I really enjoy working with you. You train me as well as I've had before, or I'm very happy to pay the premium to work with you. What am I going to say? Like, it comes under that, what you just told me about low stakes. I'm still delivering a value of care to that person. They are still, in my opinion, improving their health outcomes. So therefore, I'm very comfortable to say that I carry on treating via a personal training service for a small subset of my clients. And I don't have a problem at all with that morally. I think it's, if anything, it's a really positive thing to say, that I help people's health in different ways.
But the key thing there is that you're being transparent to the patient, the person. You're saying, this is, how are you finding this? There are other options that you can explore, we can explore. What do you want to do? And they've chosen to stay or go, whatever. But I think it's being candid with patients and really exploring their choice, their preference. Kind of, what's the phrase? A kind of jamming kind of patient-centered care down someone's throat is a very unpatient-centered thing to do, right? So patient and appreciating patients might have wishes and preferences around the sort of care that they deliver, which isn't aligned with yours. Like, if I don't receive manual therapy when I get back pain, and that's okay, but I recognise that patients really value it and find it helpful. And so to base what how I would like to be treated on how I should treat them doesn't seem to be valid. But I think being honest and open and saying, listen, there's a range of options here. These are some of the risks. See, these are some of the benefits. What sits with you? What would you like to have? And if they choose something which kind of you raise your eyebrows, then you can make a call as to whether you, again, depending on the stakes, if they're receiving, if they're medically safe to have manual therapy or some neck manipulation, and they want loads of it, I don't think you should just give them loads of it, even if it's medically safe. I think, or rather, I think there's a moment there when you say, listen, we can do this. That's fine, but I am quite interested as to why you want the particular intervention, and what value to derive from it. There may be something about their own understanding of what they think's going on with that treatment, which gives you some insight as to their own kind of perceptions and cognitions and thinking about their problems. So I think you can use that as a blanket, well, no, you're not going to get that, is probably wrong, and you can perhaps lose the patient. At the same time, just doing it infinitum because they're paying money also doesn't quite sit well, does it? Yeah. So I think you've got to build in those checks. And you say, listen, we've been doing this now, and how are you finding it? Would it be okay if I shared some other options with you? How would that sound? But I think you've got to, being candid and honest with them and checking in at those moments in care. How is this sitting with you? Can we explore other options? Do you still want to go? Because they might just be rocking up because they feel like there's some obligation to see you.
And we've sort of landed here in the slightly more ethical quandary land of owning a business that essentially can only be successful if it's profitable. And some of that can sometimes lend itself towards bad decisions around care and over-treating and manipulating someone's decision-making around what's right for them and what's wrong for them. We've touched on a lot of that over time, and I feel very comfortable in my own morality around the way I've built my business and the people we have in the business, the way that we communicate that. We do speak about maximizing statistics in terms of making sure we have a healthy business, but it always comes back to, are we adding value to that patient? Are we making sure that they are? So our business tagline is feel better, live better. And it cannot just be feel better. Are we also helping them live better? So are we helping this person live better? If the answer is yes, then are we doing a good job on the business side of that as well? And so if I was to say this to the young me, I would even imagine the young me going, oof, is that right? Is that quite right? But the more wise me and the business owner in me realizes that actually everyone is running a business to some degree. The NHS is a business in some way or another. It's being funded in one way. So we have to have some level of eye on that in the end. So how have you managed to strike that balance with the third part of your life being a business owner?
Yeah, I'm a business owner. I'm not a good business person, though. There's a difference. It's partly because I've got excellent colleagues that work with me. I think it comes back to honesty. I think when I see patients, and I guess I'm mindful that, I'm fortunate to work in a lovely part of London, and I think it's not necessarily affordable for many people, the prices of our clinic. So I'm really mindful of that. I'm kind of, I'm mindful that this is an expense for many people. That's the first thing. But I'll explore with them. What were you looking for? Like what would work for you? And part of that is that kind of length of care is going to be informed partly around cost for them. I can't presume that someone that's got back pain can afford to spend 500 quid seeing me over 2-3 sessions. I can't. That just seems like a lot of money. It seems like a big commitment. But on the other hand, I recognise there are people that are more than happy to do that and are prepared to and are able to do that. So I guess I'm interested in. So I don't assume for a minute that that people can afford this. I'm interested to know where they're at. But I have to say, I'm still probably not very good at it, as you can probably tell by my answer. I still find I find it still quite uncomfortable. I think partly it's because, as we go back to the beginning of the conversation, the evidence undermines much of some of the things that we used to see as being important and specific and valuable around seeing clinicians like us. On the flip side, there clearly is value in seeing people like you and people like me, because who else are you going to see? I mean, there are people who are suffering, unwell, in pain, aside from ChatGPT and Google. Like, there needs to be people to support these individuals, and so there's clearly a space, a social requirement to do something. But no, I mean, I as a business person, I don't have I guess I'm fortunate that I can control my kind of busyness. So if I'm not busy, no one has a go at me because it's my business. Likewise, there are other colleagues, the clinicians aren't busy, or I don't. Yeah, or if they are busy and seeing, but I kind of trust them to make the right judgment. I don't kind of peer over their numbers and you've not been busy, or you've seen this person 50 times. I'm fortunate I've got kind of ethical clinicians that kind of I don't need to kind of look at their numbers in that way. But it is hard. It's hard because, it still comes back to the individual. What are they looking for? Like, I've got patients that do come back kind of pretty frequently, and they build in kind of seeing me as part of their kind of lifestyle, like going to yoga or Pilates. And again, it's not the kind of care that I would choose for myself, but it's something that they derive value from. And I think as long as you're open and honest and say, there are other ways to go about this, would you like to explore them? And then either say, no, I'm all right, thanks. I really am okay. And like I recognize that there's other ways of going about this, but I value coming to see you. What can you do? You can't say, no, you have to be difficult to, well, I'm going to refuse to treat you. Unless there's some clear kind of psychopathology. But if it's just choice around care, sometimes I think, well, actually, maybe I'm the best person to treat them. At least I can frame the interaction in a way which I think is sensible and supportive for them, rather than anything more kind of sinister or ill-informed.
I referenced it, I think, already in this episode, but I'll say it again because I think it's important for this particular point, is that I strongly believe that I'm a better than average clinician, and therefore I am the right person for the person in front of me. And I'd rather they didn't go somewhere else in case they end up with someone that is going to pull the wool over their eyes and deliver bad care and not help that person, and then they go, oh, physio doesn't work for me, or I'm doomed, I've got to have this for life. And to me, that's the tragedy. And that I just want to be able to help the people that come in, and if I just strongly believe that, then I'm going to try and do the best version of my session every time. That performative nature inevitably comes in because I'm selling myself. I know that it's sales. There is an element of sales that comes into this. And I've moved away from thinking that that I can judge the person's value proposition, or judge value analysis. Like I'll put the proposition forwards, and it's up to them to decide. And I've had people that don't have jobs say, yeah, sure, I'll commit to that. And I've had people that I kind of superficially look at and think, you're very wealthy, and they say no. Or they kind of say it with their feet and don't come back. So I'm very open these days to I'll put my best value proposition forwards based on what I think I can do to help this person, and it's up to them to decide. Yeah, no,
I think that's completely true and fair. And having a kind of bust up with a patient over, I want to have a scan, and they say, I want to have a scan. You say, well, you don't really need a scan. You go into the whole kind of spiel about scans and how they're not, but I really want a scan. And then you kind of rupture that relationship, and they go off somewhere else to the local person down the road that does a scan and 50 treatments up front. Fine, we'll do. Let's do the scan, and we can manage the information, or likewise the kind of manual therapy. They're requesting kind of manual therapy. You don't really fancy doing it for whatever reason. You think it's not necessary, but yet the stakes are quite low, but the potential for trust and developing that rapport and to kind of meet their expectations is quite high, and you kind of not keep the patient, but you facilitate an opportunity for a bit more continued care, so you really can help them. I think that's true and good too. And these are really hard judgments to make, aren't you? When you're as a new clinician, I find it hard now, but maybe I'm just not very good at it. But as a new clinician, these are things which I don't remember being taught. Like you were just said, these ethical judgments, which they just aren't really clear answers, and being able to kind of juggle these things is really challenging.
What does the future hold for you?
Oh goodness, that's a good question. So at the moment, I'm going to work. I guess 3/4 as an academic. I mean, when it's your own business, it makes no sense to say you work part-time in your own business, right? So you can work 2 jobs, but kind of half my week is in academia as a researcher and kind of educator, and the other half is in clinical practice. I mean, I'm pretty happy with the way things are. I'm fortunate to have a really nice, good role at the university where I run a doctoral program or with a colleague, and we've got a really good group of PhD students from osteo, physio, chiro, psychology, a really good range. I really enjoy that. And then I've got my clinical practice, which really gives me a space to kind of to utilize some of this experience and knowledge that I have, which I really enjoy too. So I mean, it's probably just the same. I've got like some big aspiration to open up another clinic, or to I mean, maybe if I might get to professor one day, who knows? But if I don't, I won't be too bothered by it. But I enjoy the kind of balance that I have, and I think when I came out, I was many years ago, I was pretty disgruntled. I didn't quite know what to do. As a clinician full time didn't sit well for me. Being a full time academic had its own challenges. So for the moment, it's probably what it is. I constantly get people asking me to get the podcast up and running, but I just haven't got I just need someone just to do it for me. I haven't got the energy.
I have one of those. Thank you, Brian, over in the corner. Yeah, well, I can strongly recommend that way of doing it if you do manage to do that. And I would definitely be listening if you decided to bring that podcast
But maybe
back.
I was thinking about this morning. I should just leave it as a kind of as a relic. It was so good, and I had the best conversation with incredible people, and it seemed to really resonate with people during that time. I think to bring it back and it's just a bit rubbish, that would be a shame, wouldn't it? So
I highly doubt that would be the case, but I get your point about the relic things, and some of the best TV. 40 Towers is probably one example, right? They did 2 series and made that do. We're very happy. So perhaps that is where it lands and stays. So a couple of finishing questions here that are the traditional part of our podcast. My original realization about wanting to share content with the world came from my personal realization that my life mission is based on better never ends, and this growth mindset. And even though I was an introvert and wasn't necessarily natural at communicating, I realized that it was important enough to go out of my comfort zone and do it. So better never ends is powerful for me. But what does that mean to you?
Better never ends. I mean, it may speak to what it should speak to for me is kind of appreciating the moment. I think I'm always trying to anticipate problems and maybe not appreciating, that better is just, it just continues. So it never ends. It never really. This is the better. Like this moment here is better. And not going to overly analyse and what happens if this goes wrong and what happens if all these little, and then not necessarily related to work, but just all sorts of things. So probably just appreciating like the better is like it is now. There is nothing after this.
That's powerful in itself. Okay. And how does someone find you if they're looking for you and want to get in touch with you?
Yeah, I mean, social media is still. I've come off Twitter or X, but Instagram is probably my staple now. I forget my tag. It's like Dr Oliver _Thomson, one of those combinations. And yeah, I'm in Northwest London, and I work at HSU there, so I'm around.
Well, thanks very much for the conversation today. I did expect it to be at times pedantic look at the use of words, and I think we covered that, which is great. And thanks very much for your time.
Cool. Thanks, Charlie.
Thanks for listening to today's episode. If you've made it this far, that probably means you've enjoyed the show. Please leave us a review and subscribe to the show on whichever platform you use. I've been told that this stuff really does help us to reach more people like you. And if you are someone in charge of things at work, book a demo call with JNAT to see it for yourself. Use code PhysioCoach2MO to get 2 months free. To stay up to date, follow us on Instagram @BetterNeverEnds or on YouTube, the Physio Coach Podcast. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio, and then there's Better Physio.